We now move down another ratchet in terms of patient blood management, and we are very lucky to have a speaker from Western Australia who's exceptionally experienced in actually implementing patient blood management at a hospital level. Ms. Trudy Gallagher is the State Patient Blood Management Clinical Coordinator from Western Australia, Department of Health, and works for their Chief Medical Officer. She lives in Perth, which is handy given the distance, and is the State Patient Blood Management Coordinator. She assumed the position in Western Australia in 2011. Since that time, the Western Australian Patient Blood Management Program has gone from 1 tertiary centre to 4 embedded programs. She has specialised in this field for 15 years, so she would have seen a lot of change in that time. Prior to arriving in Western Australia, she helped expand, develop and create 3 different US patient blood management programs. Her subspecialty is iron deficiency with or without anemia, as well as implementing well-rounded PBM programs. She's been a registered nurse for over 40 years, and prior to patient blood management was a critical care nurse for 25 years. She also sits on the Australian National Patient Blood Management Steering Committee. Please welcome Trudy.
Thank you, Lee, and thanks to the planners for having me come. I think this is a valid subject, and it's an interesting way to look at implementing PBM. And why are we talking about that when we're talking about Standard 7? Well, one of the nice things about Standard 7 is that it introduces you in fine detail to the things that could help you the most. You just have to look for the right sentence and the right time, and I really struggled to try to find the right one, but 7.11 in the Standard 7 says additional information. It says blood and blood products, obviously the age is getting to me. Blood and blood product policies, procedures, and/or protocols are consistent with national evidence-based guidelines for pre-transfusion practices, prescribing, and clinical use of blood and blood products. So we're going to focus on the perioperative guidelines as an example of those evidence-based. And why are we talking about that? Well, I was asked to look at a particular program that we have embedded in. It's kind of like describing which of your children you love the most, and it's physically impossible, as you know. So therefore, we're going to use different qualities from the different programs in WA that have been uniquely successful. And also, we're going to talk about the ideal program and how you can access tools in order to attain that information. The most things you can say about standardizing, this was part of my education in this position, was you cannot standardize how things are implemented. You can standardize what your goal is for the end result. Everyone advances at a different time, everyone advances in a different way, every hospital has a different flavor or personality, and so therefore you have to adjust how you do it with each one. This is an example that we had to strive for. We had to get something generalized in order to say, what are the goals per year that implementation of a PBM program should at least obtain? You can't see this. You can have access to these slides, no problem. I'm happy to share those with you. But this was a breakdown of year by year, what you should strive for each program to obtain. The bottom line to all this is one thing. If you have, I was asked when the standards first came out to look at PBM programs and tried to share what could attain what in the standards. Guess what? If you're doing PBM, a regular program in an institution, you are accomplishing Standard 7. If you don't have a PBM program in place and you do Standard 7 to the letter, you've already started your PBM program. They work one or the other. It doesn't make any difference which one you choose. It's a win-win situation either way, and that goes for the guidelines as well. So what we're going to do is we're going to walk through these different examples of recommendations on the perioperative guidelines. The words in italics are directly from the recommendations from the little manual, and then the rest of it is how PBM accomplishes those things, whether it's specific to WA or not. I wanted to give you some guidance. So the first thing that we love the most about what the Periop guidelines say is healthcare services should establish a multidisciplinary, multimodal perioperative patient blood management program. Now, when we're talking about PBM today, for example, sometimes it's being referred to in relation to transfusion reduction. Sometimes it's being relayed in competent or appropriate transfusion. PBM programs are far more than that. Yes, they are that, but they're much more. So when I'm referring to programs, I'll show you a document at the end that will define for you what a PBM program looks like. So first of all, you got to find your heroes, your champions, and those are the people that you go to first. You find that one little niche in the transfusion committee location first. We've learned the hard way that unless you go to them before you go to administration or to your exec level, you're going to run into some brick walls later. So go to your transfusion committee, get their buy-in, then go on to exec level, then the medical staff, then the nursing staff, and then set up your next committee, which is your PBM committee. These are the key players. These are the minimums that you want to be sitting on your committees. Okay, this is your multidisciplinary committee. They are going to problem solve with you. How do you get the flow through pre-op realigned and reset up? How do you have the follow through for the post-operative patients? How do you establish something for the community so that that GP that has that chronically iron deficient patient, I don't know how to prescribe IV iron, how do I do that? How do you have those type of available facilities, and who decides how to do it? These are the members that you want to have in place. What about the preoperative anemia should be identified, evaluated, and managed to minimize RBC transfusion? Well, we have, for example, in our 3 major tertiary centers, this is set up totally different from one to the next because they found out little glitches that were unique to their center that things had to flow through. We have one center who does not even put them on a waiting list until they've gone through their initial assessment, and that's just basically your lab. Then once their iron deficiency is taken care of and they've been cleared through all the different specialists, then they can go on the wait list, then they come back in after that date and get looked at one more time before they go on to surgery. There's another center that does just the opposite because their wait list time is longer than the other center. So therefore, they go ahead and wait until it's much later, and then they do it. So it depends upon your specialty that you're looking at, and it depends upon the flow of your patients. This document is on our website. Do you look at all these patients? I mean, every single patient that's coming from surgery, do you optimize them? Do you look? No, not necessarily. This is a list that we've established. It originated in the US, but we've been using it in WA for quite a while now, and it's on our website if you want to attain it. And it basically lists the different procedures that should have that second level of assessment done, not just the RBCs, not just a CBC, but their iron stores, et cetera. These are the more predictable, larger blood loss cases. So that's how we do that. We have the anesthesia crew look at that list, and if they fall into that criteria and they don't have the iron panel done, then they go ahead and get them. What about oral iron in the preoperative setting? Yes, it is used, but the nurses in the different tertiary centers that are establishing these programs understand which patients are not appropriate to have oral iron versus those that are. There are some drugs that block these. There are conditions that are not going to be conducive to oral iron, and if you don't have a minimum of 6 to 12 weeks prior to surgery in order to assess whether they're absorbing or they can tolerate it, then you don't want to even try that. So therefore, there's IV iron category and then there's oral iron category. And in PBM, you learn to adjust your flow of your patients accordingly. But we do use it in some patients. What about ESAs, erythropoietic stimulating agents? We do have a guideline on our website in case you don't have one set up in your center, but if you look at the perioperative guidelines, they do recommend that you have something established at your center for a guideline sheet as to who qualifies, who doesn't, when it should be used, when you should not use it, for example, and what iron deficiency or iron stores need to be there before you start your ESAs, and how to time them according to your preoperative flow of your patient. The clopidogrel was already addressed earlier. The problem is that some surgeons say 7 days, some surgeons say 5 days. So your committee, your PBM committee, as well as a surgical representative for each specialty, can sit down and establish a list of these different agents and what time frame needs to be stopped. There's nothing worse than getting to the day before surgery and you find out, oops, somebody forgot to stop that drug. And then the case has to get canceled, and then you go back to square one. So therefore, that needs to be established and written down within the department. Same with aspirin, same thing applies, and with NSAIDs. Some surgeons, orthopedics, sometimes want it longer, held out before others, and other times they don't care. PAD, we talked about pre-autologous donation earlier. It's basically not done much at all in the public sector in WA anymore for all the reasons that were discussed earlier. It's expensive, number one. It's dangerous, number two. The patient goes to surgery more anemic, more iron deficient, and the studies basically say that they're transfused 50% of the time with allogeneic and autologous, and the other 50% don't even get their blood back, but now they're profoundly iron deficient, and now you have to take care of that too. So therefore, it's rarely used anymore and should not be as a regular rule of thumb. ANH, we talked about that a little bit earlier amongst the audience, and basically it depends upon your anesthesia crew. Some still say it's a great tool, others say it doesn't do anything at all. The literature is 50-50, and so, for example, the Society for Advancement of Blood Management, we've just shifted it out of our standards as an option, but not as a primary tool of PBM. Intraoperative cell salvage, of course, if you don't bleed a lot, you don't need cell salvage. So that's your first rule of thumb, is try to reduce the bleeding as much as possible. But it is available, and of course, you need to have different, if you use outsourced cell salvage teams, you have to make sure that they're in compliance with all of your PBM standards at your center. Rotom, we now have 4 Rotoms in town. One center's using it a lot. The other centers have just either obtained and they're getting used to it. There is a learning curve involved. There are some problems for logistics and how fast the results come back in order to do you any good. So those are things that each center, again, uniquely different from the next, need to get established in order to really utilize it well. TA is a great drug. We have one center that's been using it for all their elective total joints for the last 3 years, oral pre-op, oral post-op. It's dirt cheap, absolutely dirt cheap compared to IV. They've had a 0% transfusion rate on their knees for over a full year now, and about a 12% on their hips. They don't use any drains. They see that little blood from the TA. They've had no adverse events that are reportable. They're going to be publishing sometime now within the next year. And it's the first time that we'll have seen something in the literature on oral TA. They love it. They think it's great. In the cardiac sector, they don't use it as much because they're still waiting for the fine print in the cardiac population, but it's been a wonderful drug in the orthopedic population, as well as in acute injury. It's being used as well. Postoperative cell salvage, very rarely used, especially in the TA orthopedic group. I know in the United States, they're still using the Constivax and tip and drips, as we called them back there. It's not necessarily on the East Coast here, from what I've heard from different orthopedic nurses, that it's not being used as much as they used to. And there is a theory of least resistance. It actually may increase the bleeding by having the drain in, but again, it's per center policy. FFP, if you have your in-house transfusion guidelines established, make sure they're up to date with the guidelines and what's recommended. And the our dear friend 7A, we won't even go there, because the biggest issue is, do you have something in a policy as who is the gatekeeper for that decision? Who's going to make sure the phone call is made to the right sources? And is it going to be abused or used appropriately? That's the bottom line for 7A. So this is just an example of some of the things that are mentioned in standards and in the guidelines that you would want to have as measurable indicators that you have this in place, because I'd like to think that by 2017, when those standards are rewritten, we will advance to the point where we say, do you have a formalized PBM program in place? And that there are indicators established to say, yes, you do, because there are so many safety issues that are involved with PBM that I find it hard to believe that we won't get to that point. The United States is trying to get Joint Commission to get on board and say, yes, you will have this, and once you are X number of patients annually coming through your center, but they're still mulling that decision over. So these are the different indicators. These are just some of them that are on this document, which are accessible on our website. This is about an 8-page assessment tool. Our centers use it. I ask them to do it quarterly and send it to me so that I can itemize for them what is the next tool that needs to be done next in their progress through their program, what they might want to try before something else, depending upon the dynamics of their center. But these are measurable indicators. To prove to themselves we have X number, we have now 10% more to go before we're 100% complete. We have one center who is near 100% at 3 years into their program. But as Lee said earlier, there is no perfect program. You're just trying to make sure that you have all these wonderful indicators identified and accomplished eventually. Please take note of my email. I'll only be in Australia for about another year. My goal for coming here was to help get Australia the first country in the world to make PBM a standard of care. And I'm on this mission to get this accomplished with wherever anybody may need me. So please utilize me if you have any questions on how to adopt this in your own centers. Thank you.
Thanks very much, Trudy. I just wanted to reassure people that there's a fantastic package of information about PBM that's available, but there's also little snippets that you can get, and there are some samples up the back of the room there. There are some great, brochures already translated into, I think, about 8 or 10 other languages about how to, that you can provide to patients about how to have oral, important things about having oral iron, or if they're having IV iron. People can make a little inroads if it's can seem overwhelming, if you like, to take on the whole PBM piece of work. And some of that information is available locally, and there's also more information available through the National Blood Authority. And I just wanted to flag from the other speaker, Peter Barty, that I think there's a lot of private sector representatives here today, and a lot of our presentations have got the lovely SA Health Helix on them, but just about all of the blood governance groups that are operating at a statewide level absolutely welcome private sector engagement. So please come and see one of myself or someone else from the SA Health about how they can get involved.
Right. I agree. I think that there's a lot of reinventing the same wheel that's going on around the country. It's real unfortunate because this is very time-consuming work. I've mentioned several times the things that we've put on our website. I'm fine with anybody using anything that's on that website. They're just examples, they're samples. They can also be redesigned and put into your own format any way you want. The issue is that this is a international issue. And therefore, I think that the more that we network together and talk about how to get this accomplished, we've offered our services from the Department of Health PBM team to the private sector multiple times in our area, and they have not acted on that offer at all. So I hope that they understand that this is good medicine, this is good practice. They're doing a wonderful job on their standards, as we heard today, but at the same time, I think any of us here would be willing to help any of them try to get their centers up and running.
Trudy, Australia suffers from population point concentration, and in Western Australia particularly, you've got focal Perth and then these small centres.
Right.
What's your effect been with this program on getting out to the small centres, and have you seen a measurable response to benefit?
Well, what we used to consider small is no longer small because, as you know, the growth in WA has been really mind-boggling in the last few years. Joondalup, which used to be considered a small center, is now 600 beds. It is the fastest growing area in WA. When you go farther north than that, of course, the numbers drop drastically. We have tried to get the word out through all of us in the health department as far as, if you want to engage in these mini education sessions that we put on, telephone conferencing, anything you want, we'll be happy, we'll come to you. But trying to get that activated is a whole nother situation. They have to want to have us come, so same old story.
Other questions, comments?
Trudy, sorry, Lee.
No, I didn't see you, Lily.
No. Trudy, can I just ask, was there some seeded funding or specific funding put into each of those health centres to help establish the programs and have them grounded, or was it done from their own funds within?
Always a hot subject. The first 5 years was a 5-year contract. It was establishing a one full FTE for a CNC nurse to be established in each of the tertiary centers with a 0.2 of a medical director. Of course, there was a job freeze on for 2.5 years in the Department of Health, and so that kind of came to a standstill. So as you heard Lee explain at the beginning, there was only one center on board by 2011, and the funds were still sitting there and waiting. Now, the standards, I think helped promote them to take advantage of that remainder option. So we ended our 5 years in June of this year, and we've been re-upped for 1 year assessments. So we're trying to prove our worth, so to speak, and impress them that this is a worthwhile effort to renew those funds for the next 5 years. But if not, then we'll have to go to each individual center and ask if those funds can be carried over by themselves. We'll see what happens.
Okay.
Thank you.
We're now moving up to lunch, but before you go, Trudy, for those that don't know, the Western Australian PBM program has been a highly successful program. Large amount of the credit for that rests with Trudy, and as she said, she's one of those willing people that is willing to share her knowledge with anybody in the country, and it's paid for by the Western Australian government, which is even an excellent advantage. On behalf of everyone here, thank you very much for your time and coming across, Trudy.